case of thyroid or thyroidectomy. This is one of the most frequent cases that appears during MD Viva. Apurva, can you start?
Yes, ma'am. Good afternoon, everyone. My case presentation is on thyroid. Moderators for today's session are Dr. Amala Kudalkar, ma'am, Dr. Prerna Shroff, ma'am, Dr. Isha Singhal, ma'am. My patient, Mrs. Hamida Ansari, she's a 60-year-old female patient, resident of Thane, housewife. She came with the complaints of swelling in the front of the neck since 20 years, difficulty in breathing since 20 days, and cough since 15 days. She was apparently normal 20 years back when she noticed a small swelling in the front of her neck, insidious in onset, gradually progressed to attain the present size, not associated with pain. She also gives history of difficulty in breathing since 15 days. Initially, she used to feel breathless on doing household work. At present, she feels breathless even on walking a distance of 100 meters, and it is relieved on taking rest. There is no history of breathlessness in supine position or changes in position. No history of chest pain, TND, speedal edema. She also gives history of cough since 10 days, non-productive, no aggravating factors, reduced on medication, not associated with hemoptysis. She also gives history of one episode of fever 2 days back, which subsided on medication. Patient has been treated for the above complaints by local doctor, referred to our hospital for further management. There is no history of fever at present. There is no history suggestive of symptoms of hypo or hyperthyroidism. There is no other history of suggestive of compressive symptoms. Past history, she is a known case of hypothyroidism since 20 years and is on regular treatment. There are no other comorbidities, no history of radiation exposure or antithyroid drug intake. There is no history of COVID infection in the past, and she has taken 2 doses of COVID vaccine. Patient is currently on tablet levothyroxine 100 microgram once daily. She is also on tablet aciprophyllene and N-acetylcysteine, started 1 week back. There is no history of similar complaints in the family or other endocrine diseases in the family. She attained menopause 10 years back. Her previous cycles were regular and normal. Patient consumes mixed diet. Her appetite is good. There is no disturbances in sleep pattern. Bowel and bladder habits are normal and regular. Her obstetric history is uneventful. General examination. Patient is conscious, cooperative, oriented to time, place, and person. Temperature is 36.5 degrees centigrade. Height 160 centimeter. Weight 74 kg. BMI of 28.9. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. JVP not raised. No eye signs, tremors on outstretched hand or protrusion of tongue. Her vitals are pulse rate is 70 beats per minute, regular in rhythm, no apex pulse deficit. Blood pressure is 130/98 millimeter of mercury. Respiratory rate is 24 cycles per minute. Saturation on room air is 90%, which improves to 98% with face mask go towards 6 liters per minute. Her airway examination findings are mouth opening is 5.5 centimeter. Thyrometric distance couldn't be assessed because of large swelling. Upper lip bite test is class 2. Jaw protrusion, temporomandibular joint movement and neck movements are within normal limit. Neck circumference is 40 centimeter. Modified Malampati grade is 3. No loose tooth, no missing tooth. Artificial fixed permanent cap in right upper molar. Her spine and breast examination are normal. Local examination, inspection, patient examined in sitting position with arms behind the ears. Large swelling of approximately 12 cross 8 centimeter is seen on the front of the neck with well-defined margins, appears to have smooth surface which moves with deglutition and does not move with tongue protrusion. No visible pulsation or engorged veins, no dilated veins, scars or sinuses. Palpation, swelling palpated from the front. All inspectory findings are confirmed by palpation. No local rise of temperature or tenderness. A swelling of 13 cross 8.5 centimeter size is palpable on the front of the neck. Has smooth surface with well-defined margins, soft to firm in consistency. Freely mobile in horizontal plane. Movement is little restricted in vertical plane. Swelling starts from the midline and extends over the sternocleidomastoid muscle on both sides. Superiorly up to 1 centimeter below mandible, inferiorly up to 2 centimeter above the clavicles. It is possible to get below the swelling. Carotid arteries are displaced laterally on both sides and pulsations are palpable. Trachea is palpable, deviated to right side. Kocher's test is negative. Pemberton's test is negative. No palpable thrill over the thyroid gland. No palpable cervical lymphadenopathy. Resonant note is heard over sternal notch on percussion. No bruit is heard over thyroid gland on auscultation. Her systemic examination, respiratory system, trachea is shifted to right side, air entry is bilaterally decreased, no added sounds. Cardiovascular system, first and the second heart.
Anything positive? Anything positive? Otherwise, we can go ahead.
No, ma'am.
What is your diagnosis?
My diagnosis is 60-year-old female patient, known case of hypothyroidism, presenting with anterior neck swelling with difficulty in breathing and non-productive cough, which is the swelling is moving with deglutition and not on tongue protrusion. It is likely a thyroid swelling, and she is having difficulty in breathing due to compressive symptoms on trachea. There are no signs and symptoms of hypo or hypothyroidism.
Why does the thyroid swelling move with the deglutition?
Thyroid gland has attachment to the thyroid cartilage and the hyoid bone. The pretracheal fascia is covering all three of them. So with deglutition, even thyroid gland moves, ma'am.
Have you asked diet history?
Yes, ma'am. This patient, she is consuming a mixed diet, and she doesn't come from a place where there is iodine deficiency, ma'am.
So how important?
Which are the areas? Which are the areas which are deficient in iodine?
It is iodine deficiency areas are in usually hilly areas, ma'am. There is Himalayan areas. Even sometimes in the coastal areas also there is a deficiency of iodine.
Yeah, usually they are the hilly areas or sub-Himalayan or Dhule or Satpura region in Maharashtra. These are very common as the iodine is washed away. Okay. What drugs this patient is likely to be on? A patient with thyroid swelling, what drugs the patient is likely to be on?
My patient is on levothyroxine, ma'am. Other drugs patient can be on the anti-thyroid drugs like propylthiouracil, carbimazole, methimazole. They can be on beta blockers, that is propranolol will be started. They can be also on Lugol's iodine, ma'am, which will be started pre-operatively. And since my patient is on cups, in order to control cough suppressants can be started. That also contains iodine. And lastly, if patient does not respond to any of this radioactive iodine therapy also they give.
Can thyroid abnormality be as a result of some other drugs?
Yes, ma'am. Antiarrhythmic drugs like amiodarone, it causes hypothyroidism. Then lithium carbonate, which is antipsychiatric drug. Then paramino benzoic acid, and even large doses of iodine containing syrups are used. Then also they can cause hypothyroidism.
Yeah, so during history, the consumption of all these drugs you must ask. Okay.
What are the clinical features of hypo and hyper? You said your patient could be hypothyroidism. Clinical features, how will you distinguish?
Hypothyroidism patients will complain of easy fatigability. They will have weight gain despite they have a loss of appetite. Sleep disturbances will be present. Constipation, menstrual abnormalities will be present, like menorrhagia. They will complain of cold intolerance, and there will be bradycardias, arrhythmias are more common in them. And hyperthyroid patients, they are usually thin-built patients who will complain of anxiety, nervousness, tremors will be present, weight loss despite appetite, heat intolerance will be present, diarrhea, menstrual abnormalities can be in the form of oligomenorrhea or amenorrhea.
Which are the hormones which are secreted by thyroid gland?
Two hormones are secreted. One is the thyroid hormone, that is the T3 and the T4, which are secreted by follicular cells of thyroid gland. The parafollicular cells will secrete calcitonin.
What is the difference between T3 and T4? Which is more active?
Ma'am, T3 is more active, more potent. From the thyroid gland, 90% T4 will be secreted and 10% T3 will be secreted, ma'am. And peripherally, T4 will be converted into T3, which is the active form.
Okay. What is Jod-Besdorf phenomenon? Very often you are asked in exam.
It is an iodine-induced hyperthyroidism. That is, especially in the patients of patients who are iodine deficient and have features of hyperthyroidism. If we give them externally iodine, the symptoms of thyrotoxicosis will worsen, ma'am. That is Jod-based phenomena.
So it is more or less opposite to Wolff-Chaikoff phenomenon, where it causes extra iodine, causes suppression.
Hypothyroid.
Okay.
What are the features of retrosternal goiter? What do you say there could be in your patient?
In the history, patient will give symptoms of dyspnea, dysphagia, then change in the voice. Also, they will complain of dyspnea on supine position. Then in the signs, there will be dilated veins will be present in the upper part of the chest. Then on palpation, it is not possible to get below the swelling, and there will be a dull note on percussion on sternal notch. These are the signs of retrosternal extension on history, ma'am, history and examination.
So, dyspnea, dysphagia, hoarseness of voice can be present even in absence of retrosternal goiter. Only thing is retrosternal goiter, all these signs will be more pronounced. Plus, the dilated veins will be seen particularly in case of retrosternal goiter. Therefore, it's very important to elicit sleep history in case of thyroid patient. In which position the patient is more comfortable during sleeping. Okay. Now this patient is for thyroidectomy. So what investigations you are going to ask for?
Blood investigations, hemoglobin, complete blood count, kidney function test, liver function test, coagulation studies, and specific to thyroid function test, that is T3, T4, TSH will be asked. Then chest X-ray, PA view. Then if in order to look for the presence of tracheal compression and deviation, and also for mediastinal extension of the swelling, I will also ask for X-ray of the neck, AP and lateral view. CT scan of the neck will be asked in order to look for the tracheal compression, mediastinal extension, and also compression of the other mediastinal organs. Then indirect laryngoscopy in order to look for the movement of the vocal cords, which can also be confirmed by USG of the thyroid. And ECG to look for the presence of bradycardia, tachycardia, arrhythmias if it is present, and also to look for to rule out cardiac involvement symptoms of IHT, so signs of IHT.
So why you want to ask for CBC?
CBC, if the patients are on antithyroid drugs for a long time, they are known to cause agranulocytosis, ma'am. So the total leukocyte count, the platelet count will be reduced. And also in association with thyroiditis, when there is inflammation, the total leukocyte count can be increased.
How hemoglobin is important?
Hypothyroid patients tend to have anemia. So preoperatively, baseline hemoglobin needs to be taken, and also we can also calculate the maximum tolerable blood loss with the hemoglobin, and also arrange for the blood when they are posted for thyroidectomy.
So thyroxine is needed for maturation of RBCs. That is one reason. And because of the antithyroid drugs can suppress all the series of the bone marrow. That is another. Okay. Now, hypothyroid patient also can have menorrhagia, so that can also lead to anemia. Yeah. You said thyroid specific hormones T3, T4. So you want to do total T3 and T4 or free T3 and T4? What is the difference between the two?
First will be the TSH will be looked. Then when it comes to T3, T4 and free T3, T4, T3, T4 is the hormone, is the thyroid hormone that is bound to the thyroid binding globulin, albumin, and transthyretin. The free portion or the unbound portion is responsible for all the effects on the systems of the body. Free T3, T4 levels are specifically useful in conditions like pregnancy, where the total T3 and T4 will be increased because of increased TBG levels. And also in case of a chronic illness like hypoalbuminemia, because of which the free fraction of T3 and T4 will be increased. And also when the patient is started on antithyroid drug therapy, TSH is not reliable to tell whether there is a response to the therapy. Free T3 and T4 will help to confirm that the patient has a response to the antithyroid drugs.
What is subclinical hypothyroidism?
It is that is the TSH will be elevated, but the total T3 and T4 levels will be normal. This is subclinical hypothyroidism.
So elevated is up to, is there any range beyond which you should not be inducing anesthesia in these patients? What is acceptable level of TSH?
TSH, the normal level is 0.4 to 5 is the normal, 0.4 to 5 is the normal level. And if it is in the range of 5 to 10, we will see for the levels of free T3 and T4. If they are normal, patient can be taken up. If it is in the range of 10 to 20, in that case, patient needs to be evaluated, treated, and then only needs to be taken.
Yeah, it is a dictum that usually, as far as possible, an elective patient should be rendered euthyroid prior to taking up for surgery. I mean, this patient is already dyspneic. And if you prolong the therapy and defer the surgery, patient may end up with stridor. So that call you have to take. Any other investigation you will do? What about flow volume loops?
Yes, ma'am. Flow volume loops will tell about whether there is a subclinical dynamic obstruction in the patients. So when the goiter, there are two types, that is the extrathoracic and the intrathoracic obstruction can be commented. When there is extrathoracic obstruction, the inspiratory loop will be affected. And when there is an intrathoracic obstruction, the expiratory loop will be affected. When there is a fixed obstruction, there will both inspiratory and expiratory loop will be affected.
Do you have pictures of X-ray neck or a CT scan in your presentation? Then maybe we can discuss,
This is the swelling of my patient, which I am presented just now. This is a X-ray.
Yeah, so in the first, you can actually see the rightward deviation of trachea. In AP view, what you will see? Deviation or compression?
In the AP view, deviation will be seen, ma'am, and also the compression can be seen in the AP view.
Yeah, so scabbard trachea, which happens as a result of side-to-side compression, also can be seen in AP view. Whereas in lateral view, it is mainly the compression that you appreciate. You can go through the slides.
This is the CT scan of the same patient.
Yeah, you can go ahead. Next slide. Next slide. Yeah, you can see here mainly the swelling is in the thorax, and you can see the rightward deviation as well as compression, side to side compression of the trachea. Next slide. So it is very important. It is very important to have CT scan done. Radiological imaging carries a lot of importance in case of thyroid swelling, which is huge and symptomatic. Whenever you are checking for what you are interested in is the position of trachea, it's whether it is compressed, whether how far the compression is extending, whether it involves carina also, and its effect on the great vessels in the mediastinum. Next slide. Here you can see there is trachea is on the left side, deviated on the left side. So the patients in whom the trachea is deviated to left, they are really difficult to intubate, and in them the external laryngeal maneuvering to the right, it is not possible actually. Next slide. Yeah, the same deviation on left side and compression. So luminal narrowing, the exact dimensions of the trachea you will get to know from CT scan. Any other investigation you would like to do, Apurva?
One is the CT scan we have done. The new one that is introduced is a virtual bronchoscopy, ma'am, where the three-dimensional CT scan, along with that computer processing will be done so that the entire airway can be visualized.
Yeah, this is especially important in cases of CA thyroid, whenever there is infiltration, you are suspecting infiltration inside the trachea. Okay. Any other investigation? You did mention about CT, USG neck. So what you will see in that?
USG of the neck, one is they will comment on the thyroid gland, how is the consistency, how much is the enlargement. Other one, we can look for the anatomical landmarks that are present, that is a cricoid trachea and also the hyoid bone. The movement of the vocal cords can be seen on the USG, ma'am. This is important, like preoperatively, where we do indirect laryngoscopy to comment on the vocal cord movement. So even USG can be used for this purpose.
Yeah. USG or even nasoendoscopy, you can actually see the movement of the cord, or 70-degree scopy. Now, this patient is for surgery, thyroidectomy. So, what preoperative orders you are going to write?
Preoperatively, I want to counsel the patient first regarding the plan of the anesthesia, post-operative ventilation she might require, and starvation will be according to the standard guidelines, ma'am. Most important thing is this patient who is having a large thyroid swelling, the night dose of anxiolytic which will be given should be avoided, ma'am. No night dose of anxiolytic or sedative should be given. Even like the sedation, it has to be given, should be given under monitoring, ma'am.
So, how you are going to prepare trolley? The next day, patient is about to be taken on table. What trolley preparation you will do?
Ma'am, my plan for this patient is awake fiber optic intubation. My difficult airway card preparation will consist of face masks of different sizes, then oral airways and nasal airways of different sizes, the laryngoscope, rigid laryngoscopes of different sizes, then video laryngoscope, CMAC, then flexometallic tubes I will be using, so of different sizes will be kept ready. Then LMAs will be kept ready, bougies, airway exchange catheter, then suction catheters, then resuscitation ambu bag, and rigid bronchoscope standby should be kept, and face mask and Hudson mask will be kept.
But why you want to have a rigid bronchoscope?
Ma'am, in case of emergency, cannot intubate and cannot ventilate situation, in that case, with a rigid bronchoscope, we can pass, and it will help to oxygenate the patient, ma'am. Or like
Any role of CP bypass?
yes, ma'am. But it cannot be used in emergency situation. If CP bypass is planned, it is first only it will be decided, and also for if there is a retrosternal goiter extending into the mediastinum and it requires thoracotomy, at that time CP bypass standby will be kept. But CP bypass cannot be used for emergency.
Yes, it has to be planned earlier. In that case, femoral artery and vein should be dissected and at least encircled. Last moment you cannot do all these things. Okay, so now you want to go ahead. You have decided to do it with fiber optic bronchoscopy. So how you are going to anesthetize the airway?
When the patient comes on the day of the surgery in the pre-anesthetic area room, first IV, if it is present, I will check the patency of the IV. If it is not there, I will take an IV. Baseline saturation BP monitors will be attached. Then I will proceed with the preparation for the airway preparation for the fiber optic intubation. I want to give an anti-silodoc, that is 0.2 mg glycopyrrolate. I will give IM. This will decrease the secretions, which will help for the fiber optic intubation. After this, since I'll be putting tube by the nasal route, so nasal decongestion, I will put oxymetazoline nasal drops. Then also for anesthetizing the nasal cavity, I can put lignocaine gel and ask the patient to sniff. Then after all this, in the sitting position, patient will be given 10% lignocaine viscous gargle. After that, 4% lignocaine nebulization will be given for anesthetizing the trachea up to the level of the carina. After this airway preparation, patient will be taken on table. In addition,
what airway blocks you will give? What airway blocks you will give?
Ma'am, airway blocks. If it is not a huge swelling and the landmarks, that is the hyoid bone, is palpable, we can give a superior laryngeal nerve block. And again, if the trachea is also palpable, cricothyroid membrane and trachea is palpable, then we can give a transtracheal block. In my patient with a distorted anatomy, it might be difficult to give based on landmark guided this, but with the help of USG, if it is possible, we can mark and we can give the.
Or you can just spray as you go.
Yes, ma'am. So patient will be taken on table. One more, so the total amount of the local anesthetic that will be given will be calculated first, and then only it will be divided how much should be given in the airway for anesthetizing the airway, ma'am. Patient when taken on table, monitors will be attached. Then for awake fiber optic intubation, the difficult airway cart will be checked and kept ready. Then
which tube you will select? Which tube you will select?
Ma'am, for my patient who is having tracheal compression and deviation, I want to put a flexometallic tube via the nasal route.
Okay. And how you are going to check the position of the tube?
Position of the tube has to be checked soon after intubation, and also once when the final surgical position is given. So in the surgical position, they will give a head extension will be given with the head rings below the head and the sandbag beneath the shoulders, with the arms that are abducted and pulled down. So there is a chance of the tube will come out. So the final position of the flexometallic tube has to be checked again after giving the final surgical position.
Okay. How you are going to maintain anesthesia?
Maintenance of anesthesia, ma'am, with the inhalational sevoflurane and with muscle relaxant. The intermediately acting muscle relaxant will be given with neuromuscular monitoring, ma'am.
Okay. Monitoring?
Monitoring saturation, blood pressure, ECG monitoring, temperature monitoring, EtCO2 monitoring, neuromuscular monitoring, and monitoring of airway pressures should be done intraop.
Why airway pressures?
Ma'am, intraoperatively, airway pressures can increase because the surgeon is when the surgeon is operating on the neck, because that is around the trachea, because of the external compression, airway pressures can increase. And also the tube might migrate inside, and endobronchial intubation, if it happens at that time, also airway pressures will increase. Or if the tube gets blocked because of the secretions, airway pressures will increase. If there is a kinking of the tube, or if the thyroid swelling also has a intratracheal extension, it can get blocked because of the tissue. In all these cases, airway pressures will increase, ma'am.
Suppose during your monitoring, you find that the EtCO2 value is suddenly it has become 0. So what does it mean? Patient has arrested?
No, ma'am. First, I would like to check if there is any disconnection from machine to the patient end, and also with the in thyroid surgery, because they are giving a head extension, there is a high risk of venous air embolism, ma'am. So that could also be the cause for falling EtCO2.
More than head extension, it is the 20-degree header that you give to facilitate venous drainage. So that places the neck veins at negative pressure, and that can suck in air. So that you have to remember. Suppose the EtCO2 is increasing, there is tachycardia. What could be the reason? EtCO2 say 50, 55, there is a severe tachycardia. So how you are going to manage this?
One is it could be because of exhaustion of the soda line. or I would also look on the other parameters. What is the heart rate, blood pressure, and also temperature, ma'am. If there is increase in temperature, tachycardia along with rise with EtCO2, then it could be because of thyroid storm, and also malignant hyperthermia could be another cause, ma'am. And also, if the patient is having a pheochromocytoma also, intraoperatively they can present with tachycardia and hypertension, ma'am.
Will you insert rice tube in these patients?
Yes, ma'am. In a Riles tube has to be inserted. That is because intraoperatively, if the patient has thyroid storm, Riles tube can be used for giving cold saline washes, and also to give the anti-thyroid drugs, that is propyl thiouracil or methimazole via the RT. And also when the anatomy is distorted because of the huge goiter, surgeons will require the Riles tube in order to identify the esophagus.
Okay. So what are the intraoperative problems you expect?
Intraoperatively, one is because of the surgical position, and surgeons are present close to the airway. There is a chance of tube displacement, tube disconnections will be present. Second one, the airway pressures can increase, as I told before. Third is the bleeding that can occur. Fourth, fourth is thyroid storm, which I told.
Okay. Suppose you see, you feel that it is a thyroid storm, then how you are going to manage it?
Surgeon should be informed, and they should stop the surgery. Then I'll give supportive treatment and the specific treatment. Supportive treatment increase the FiO2, because in thyroid storm, basal metabolic rate will be increased. So increase FiO2, and also patient will get dehydrated. So give IV fluids. Via the RT, I can give cold saline washes. Then cooling can be done by giving paracetamol. Then anti-thyroid drugs I will give, that is propyl thiouracil in high dose, that is 200 to 300 mg via the RT, or you can also give methimazole also. Then when the patient is having if the patient is having tachycardia, for that beta blockers will be given. Here propranolol I will give, because it also has extra effect of preventing the peripheral conversion of T4 to T3. Steroids also will be given, ma'am. That is dexamethasone 8 mg IV. It will prevent the peripheral conversion of T4 to T3. Then potassium, sodium iodide can also be given IV 1 gram. And iodide,
that you will give prior to propyl thiouracil or afterwards?
After giving anti-thyroid drugs, propyl, that is propyl.
Yeah, at least after 1 to 2 hours. Okay. Now the surgery is over and you are about to reverse and extubate. So any particular precautions or anything specific for extubating a patient of thyroid swelling?
Ma'am, two things. One is the vocal cord movements I will have to confirm. Second one is in long-standing goiters like of my patient, there is tracheomalacia will be present. So so before extubation, for looking for the vocal cord movements, that is we can pass the fiber optic via the opposite nostril and look for the movement of the vocal cords. Then for the patient can also have a laryngeal edema. So for that, I would want to do a cuff leak test, ma'am, before extubation. And also to look for the trachea malacia also, FOB can be passed, and sequential extubation can be done.
What is sequential extubation?
Ma'am, in case suspected cases of tracheomalacia, we will pass the FOB via the flexometallic tube, and then slowly we are going to take out the tube under the FOB vision and look if there is a tracheal collapse. And or we can also put a airway exchange catheter and take out the tube, observe the patient for 1 to 2 hours, and then remove the exchange catheter. This will also help to re-intubate if the patient is having a respiratory distress.
Which type of cord pulse is more dangerous?
Ma'am, bilateral partial recurrent laryngeal nerve palsy is more dangerous. This is because the abductors will be affected, but there will be increased action of the adductors. So the patient will require an emergency. We have to secure the airway. That is tracheostomy.
What happens? Yeah, what happens during bilateral complete palsy?
In case of bilateral complete palsy, the vocal cords will be present in are present in paramedian position,
Cadaveric position.
cadaveric position. So the patient will have respiratory distress, but it is not so much like the bilateral palsy. There is increased risk of aspiration in this case, and patient will have voice complaints, ma'am.
What are the causes of
Yeah.
tetany? There could be tetany.
Postoperatively,
Findings and causes.
Causes is if the parathyroid glands have been removed completely during the surgery, or if there is ischemia to the parathyroid gland because of the surgery, hypocalcemia. These are the cause for postoperative tetany. It can present as laryngospasm, seizures. Patient will usually complain of circumoral numbness. Then Trozic sign and Bostock sign will be positive.
Any special tubes that you can use for, you said vocal cord palsy can occur, recurrent laryngeal nerve. So any special tubes that we can use?
Ma'am, we can use EMG tubes, that is the electromyography tubes can be used. This can be used for recurrent laryngeal nerve monitoring intra-op, ma'am. This is especially indicated in case of thyroid tumors, or when they are doing a redo surgery and there is already preoperatively patient is having a recurrent laryngeal nerve palsy, they can monitor intra-op. I have this is the EMG, that is electromyography tube, which is used for recurrent laryngeal nerve monitoring.
Suppose there is a hematoma in the neck following surgery. How you are going to manage these patients?
When the patient is shifted post-operatively, always suture cutting scissors will be kept next to the patient. So we will immediately have to cut the sutures to release the compression on the trachea. So soon after that, we will have to intubate the patient. The more time we intubate, the more airway edema will occur, and it will be difficult to intubate. And immediately patient has to be taken up for the OT in order to control the bleeding.
Okay, you are doing extremely well, Apurva. Just last question. If this patient comes to you for non-thyroid surgery, say any emergency surgery, how you are going to treat? Patient is hypothyroid with big swelling, or say perforative peritonitis.
Ma'am, perforative peritonitis, it has to be taken as an emergency, but preoperatively, I would like to see the thyroid function test to see like her TFTs are normal, patient is euthyroid, and also since it is a case of peritonitis, patient should be started preoperatively and antibiotics, then IV fluids has to be given, and for the plan of the induction of anesthesia, in this case again, awake intubation only can be done. If it is, we can do the awake intubation with a video laryngoscope, or the fiber optic bronchoscope, ma'am, whichever is available. That is it.
Okay.